because they received the WHO. So thank you, these two communities that were with us last time. Now my question is for both communities, from Pilar and María Ángeles. We've listened to Tomás. He said one of the most important goals is to maintain the talent before having new talents. What are the strategies of each of your autonomous communities to maintain the talented professionals in your communities? Well, we all know that our future professionals in health, they're going to end starting in September. I'm from Aragon, as I said before, that from 2024 to 2027, all the specialties that we have in primary healthcare, more than 200 professionals are about to finish working. We have to do something. They are about to retire, so we have to do something about this. We gotta get new professionals to substitute these ones that are going to retire. We're working now in this project because in my autonomous community, Aragon, we have very good professors that really educate our future colleagues on what is really primary healthcare. That's the core, the basis of the public healthcare. And for this, we're taking a series of measures so that they stay with us, that they get stabilized in our territory. The stability, flexibility, all that they are asking for. I'm saying that the majority of the health professionals that we are in the public system, majority of us, we are women, and it's very important that this time flexibility is a reality to be able to balance our daily lives with our work. We are looking for this balance to believe on the professional. As I said, I am a family physician and I am a rural physician from a village. And I say this with pride always. And all the facilities I always had, or that we could had, when getting a good balance between daily life and work, we want this to become a reality in the whole country, because we defend training and we defend excellency, and our future colleagues are excellent, and we want to enhance this continuous formation of health professionals that are right now part of the 21st century primary healthcare. I think it's very important to remember that primary healthcare this century is created by many different professional categories. It's not just about medicine, but also about the importance of nursery, among others. Thank you very much. I would like to start with the last words that Pilar said, mainly to tell them to you, María Ángeles, mainly because of continuous formation, training. What are the initiatives that you have from the community of Castilla-La Mancha about continuous training of professionals in primary healthcare? Well, really, we had an important development, a very important development in Castilla-La Mancha. We are totally committed with training, with innovation and research, and we great committed with primary healthcare through European funds. We've dedicated a lot of importance to decide and to think about and analyze within the professionals and our primary healthcare leaders what information would be more relevant for our primary healthcare teams. Always thinking about this multidisciplinarity and taking training to all the team. We're working so much also on empowering the tutors In Castilla-La Mancha, we've published already in 2019 the rule, the decree 84/19 that talks about themes related to recognition, incentivization, remuneration that all the professionals in health should have, and that they are working and being the guide of our next professionals, our future professionals. It's very important that our future professionals, our residents, they know primary healthcare. They are emotion with it. They love it. So that's why it is so important to have a continuous work and collaboration with the universities. How relevant the time is in the plans of medical academies, the weight of primary healthcare education must be bigger. We have a good experience with Rural Erasmus, that it's giving us great benefits. Because the ones that go through this training, is easier that they want to stay in what they're learning. About this, we think it's very important to work on investigation and research. We have to make our professionals have this possibility to research. We think we have to have quantitative measures related, as we've been saying the whole day, with retributions, stability, with the contractual relationship, with this offer, attractive offer. We have a special plan on which our professionals are offered 3 years after finishing training. And I think it's a way that they stay here. Thank you very much, María Ángeles. You can keep talking, but you're talking about the future questions. So I'll send the ideas that Thomas was talking about, and I think that you've anticipated them already. But we will talk about them deeper afterwards. Thomas was talking about that this new generation of professionals need some reinforcement that we wouldn't think about them before. And I would like to ask about this, but what enhancement, as representatives of the public administration, that you can do, can you offer to the professionals of primary health care? I'm talking about any kind of incentives, not just salary, but time flexibility, possibilities for researching, all the elements that can attract the future professionals. I would like you to tell us a little bit, first Pilar and then María Ángeles, in what strategies are your autonomous communities working on? Well, primary healthcare physicians, we are not just all the ones that we work on primary health care. Apart from being or working on nursery, healthcare, psychology, we are clinical researchers. So, as I was saying, we have to enhance and give the opportunity to do these tasks that are so important in the daily lives of these primary healthcare professionals. About stability and flexibility, we will propose job stability, long-term contracts, as law allows it, is 3 years of exercise, so that they can stay in. Yeah, they can stay in the territory. I don't remember very good what I was talking about. Listening the professionals and check what needs, personal or professional needs do they have. Was the plan that our people, our colleagues have from the different areas of health on the national health system. Aragon, as I was saying, is an autonomous community where the majority of population, it is in the capital, Zaragoza, and the 45% is in the rest of the provinces. And with this, for people, so that our colleagues can stay, we don't have to give a only measurement just for the region, for the autonomous community. Each zone has their own characteristics. So we have to check what type of offer we can give them depending on if it is a rural environment or an urban one. It is important to sit down with the colleagues and listen to them and to hear which are their needs. If we had a listening administration, we can go forward and responding the needs that we have right now in the primary healthcare system. So maybe we don't need to change this model, but the adaptation of this model to society is what we may need to change. Well, I completely agree with Pilar. I think that to start as you finished, I think that we have a great health model, a great primary healthcare model that really needs a reorientation and to get adapted to this change of paradigm and to these new goals in the world. Goals on which primary healthcare has to work and where it is important to check what can we do with our health professionals. Conciliation, stability plans, time flexibility that allows us to give them 3 years of practice. That it was set it in the 84 order that allows us to let them stay for 3 years so that they can really connect with the community. I think we also have to work on the teaching area to guarantee and create new teaching areas to have places with residents that know the community, that grow in the community, and that this allows them to stay and that we maintain the talent. I agree that we are working with a different generation, that they have different needs, and we will have a transformational leadership. I wouldn't say a future leadership, but a present leadership. We have to have our eyes set on the present. We have 80,000 square meters on our autonomous community. So we need to have 203 health centers, a lot of heliports, and that it makes that in many places we need to have 4 doctors instead of 1. And this gives us a scenario that allows us to work within the professional needs. In both communities, we have a roadability component that is very important. I won't get in what strategies do you have, but I know there are other people on here. So if you have any program, any initiative, any specific initiative to increase the talent in the rural areas, if you have any example or any program, any specific experience, we're working in this organization model, as she was saying, due to the geographical amplitude it exists. Maybe on a zone we have 5,000 people on 5 villages. We might need 5 physicians, but if we have 5,000 plus people in 18 communities, maybe we have to work on the amplitude. So we have to study everything, depending on the territory. We have to take into account that among all the districts that we have, all of them have around 500 inhabitants. And when it depends on where they live, they'll have to have a right for health assistance, quality health assistance. And this means to maximize the resources. We have to optimize the resources, not just the material resources, but also the human resources. And we have to make that the professional feels motivated, that they believe in this primary healthcare. We are the first ones that, as a primary healthcare group, we have to believe on what we are. And this is a main point to be successful on the organization of the new primary health care model. Also work on the adaptation of the new model, on the strategy, on the primary healthcare strategy. We cannot forget that we are family and community. And in this new community that we're talking about, it is very important to know, to execute, to do it, and to get advantage out of it. It is a complex matter. I start with what Pilar finished with. Primary health care would be communitary or won't be. So I think our communities, with all these characteristics, with a high rural territory and geographic dispersity, I, for example, see people from Guadalajara that are here, or we can talk about Cifuentes that has less than 200 health cards, but has a huge number of municipalities. So it forces you to work in a specific way. We're working on reflecting and having a model that allows us to face the needs of the professions that are difficult to cover, with the needs that express the lines that we can follow to cover all the needs. We have a model that is joined to different degrees of dispersion that allows us to get different professionals that, depending on the territory they work on, they have to have different resources. I think it's also very important to work on the resolution capacity so that these municipalities, these places, also have covered the needs that we are working with them in other health centers, so that we use innovation. I'm not talking about the new things, because not all the new things are innovating. We have to give this population the ability to do valuable things for the community. Work with the community, as Pilar said, but I think we will also need to think about the financing. That during today, we've been talking about this a lot. Financing cannot just be correlated with money, but with other places. We're talking that being rural, geographical dispersion makes us work with a specific number of professionals. And we have to take all these criteria into account when talking about financing. Okay, thank you very much. We're running out of time. So now we will ask you please to give short answers. But we would like you to give the opportunity to all the people here, if they have any question to María Ángeles or Pilar, or maybe to give their own opinion if someone comes from another autonomous community, so that they can express their own opinions. Micros are open. If anyone can want to give their opinion on their own autonomous community point of view. There's a question there, please. It would be nice if you could have the microphone. Can you present yourself? Yes. Good afternoon. I'm Eva Suárez. I'm a General Director of Primary Healthcare in Comunidad Valenciana. And I wanted to ask my colleagues from Castilla-La Mancha and Aragon how would it be in summer if our professionals end up studying in May and not in September, if they have any solution? Because I'm looking for a solution and I cannot find one. So maybe the meeting that we had the other day with the ministry and the responsible of human resources, obviously, as you were saying, we were thinking about the situation that our future colleagues are going to finish in September the residencies. In Aragon, we are going for a training plan on a special that ends up in September. But as it is said in the 2005 plan, supervision has to be personnel from R1, and in a proportional way, they have to have some autonomy for the residents that are about to end. We told this to the residents. We're working on the draft of the other. They are qualified professionals so that they can practice on a teaching center. And they can work by themselves if they have someone supervising them. So autonomy and the exception and the perfect training that they have, I think, at a national level, but in Aragon for sure, so that they can work, but with someone supervising them, always in a voluntary way. Yeah, very specific. We are working on the same line. We're working with the General Direction of Human Resources and Transformation to check the opportunities that we can have in order to guarantee the needs that the citizens have to have the professionals that we need in our autonomous community. My question is what the paper of the primary health care. I know that multiple countries in Europe, the presence of departments of family health care in the context of medicine universities contributes a lot to the development of a very strong primary health care in all the countries. For example, in my country, the role in the development of primary health care of the family health care department in the university is so important, very important, not just for research, but also for the development of the organization of primary health care. How is it in Spain? What is the contribution of the university departments on the training and the distribution of family physicians and professionals of primary health care in the different territories? This is a very accurate person and the best person to answer at a WHO level. Thank you for the question. And Tomás Zapata also talked about this, that in this moment we don't have departments in the universities, and this would be one of the points and recommendations that we did when we did the case study. So I think this question, we have to make this question to the organization, and it should be a coordination between different ministries. And this is important in Spain so that the people that come from a international environment, they have no family physicians departments, specific ones. There are some communities that have some departments, but in fact it is something that we need to do since the appearance of family medicine in Spain. Thank you very much indeed for this question. So it's your turn, Paloma, to keep on with the round table. Thank you very much. to the people talking. I'm not gonna move. I think we're gonna going forward to the next block. Sorry that we're going on a rush. We're gonna rush, but we want all the people here in the stage to talk and also the public. So we encourage you to make questions, even though we're running out of time. We'll try to do all in time. Second block, this management of the demand. And in first place, I'm going to present Remedios Martin. She's a president of the Spanish Society of Family and Community Medicine. Since July 2022. Esther Nieto, she's a president, Federation of Family and Community Care Association, Family and Community, and an anthropologist at the same time. And she's the president of the FAECAP, the Federation of Family and Community Care Associations. At last, we're presenting Miguela Arevalo Garcia. She's a social worker in the mental health department in the Hospital Ramón y Cajal, and right now the president of Spanish Association of Social Work and Health. And we're making the same question for the three of you. Which are the ideal components that we can find and define inside the multidisciplinary team? We've been listening how the role of the professional nurse is something claimed at an international level, and something that it seems that it exists some agreement that it might be some of the keys to deblock the situation that we have. And we wanted to ask, what tools do we have to enable this work in a multidisciplinary team? In the ministry, we keep on working in this publication that we're going to publish soon, and that will give us some tools to work on this aspect. But we would like to hear your perspective, your point of view.
Thank you. Should I begin? Well, I will begin. Me as a family doctor and as a primary healthcare doctor or representative for it, I should start by saying that PHC has over 40 years of history in this country, and we have made drastic advances in this sector. Doctors and nurses were the only actors of this model in the past, and now we're working towards a model that is focused on the citizen, focused on the patient. And now we are working for a threefold model composed of a nurse, a doctor, and a manager or an administrative. For the first contact is made by administrative personnel, and now more than ever they are managing the whole demands that our citizens may have, and they play a crucial role when it comes to directing the patients and the professionals that should take care of them. This way, through a well-trained administrative, we can work on the whole competence set. We speak of competencies or skills because we all have to make this step, not only us, but also the administratives. Many of them have trouble when it comes to managing the claims or demands. But we have to work hand in hand with them. Some regional communities and regional governments are working on it, and the administratives can perform this work and can derive the patient to the most suitable doctor or nurse. But the debureaucratization also makes the administrative part of the triage, of the sorting and we all share this view. The doctors have to work as doctors, nurses as nurses, and the rest of the team has to collaborate. We'll have our assistants, our social workers, and our administratives. And we really have to make sure that they receive the proper training in healthcare. We have to introduce changes on the Marco setting, but they have to bet for it, as well as other roles. Dietists, physiotherapists, other kinds of experts, and we have to introduce a community level view, which will favor the education of our citizens in healthcare and will help us develop in specific techniques. Thank you, Remedios. Esther, I believe, linking with what Remedios said about empowering the patients and making the healthcare centers also part of the community, I'd like to see your perspective. Well, above all, I would like to share my happiness with you, for I have heard many times about community and family medicine. I think this is a fundamental grounding for the future development of our field. For this will bring us a wholesome skill mix, skill setting that are aimed towards what we call healthogenesis and not a doctor-centered approach. So we should empower the community, the development of these patient skills as a fundamental basis. When we speak about the tools that we have to remember, we have to bear in mind that we have them at the end of the day. And we have to make clear what we have and how are we going to develop those competences in a way that these trained professionals, the specialized physicians, primary doctors, assistants, nurses, that we are all able to know what are the workflows. We also have to make sure that our patients know who is this personnel that is going to help them and guide them through the process and keep them updated. And one of the things that we have already spoken about in other occasions is that we have to focus, we have to center our care in the person, in the patient, but we have to switch the numbers. So we have to think about which professionals are going to be needed. We are experiencing the phenomena of chronicity and an aging population. So we will have to address these illnesses from the very same community, from the very same household. So we will have this threefold setting: nurse, doctor, and administrative, but we will not have the same personnel assigned. It would not be fair. And this is a leap that should be introduced in primary healthcare. Well, thank you. It is a responsibility as well as a pleasure. I just want to remind everyone that the Royal Decree on the basic healthcare structure is released in 1994, which includes also non-directly personnel that is not directly trained in healthcare. So it covers social workers, administratives, and social assistants. And I believe that this addresses the definition of health, which is the obtention of a wholesome life in the social, health, and personal fields. I consider that the problems that vulnerable people and ill people suffer are to be treated, are to be conducted by this law, by us. What is the problem now? We do not have social workers all around the country. And when there is a part of the workforce that works in the social services, they are very few. So in the context of PHC, we have to rethink this whole issue. So we claim that we should have more social workers, at least one per healthcare center. Also, even though we are not healthcare professionals per se, we tend to be left out of the training initiatives. And I want to make a point because we are part of the basic aid team and we are left out of these training opportunities. And we claim that healthcare social work should be addressed and should be considered and regarded as it should. We all need to receive a proper training. We have been working in healthcare for over 2 centuries. I think we are at the same level as nurses. I don't want to make you scared, but we have a series of claims for us to feel more comfortable, for us to feel represented, for we work hand in hand with the healthcare team, but we are the others, and we are regarded as the others. Also bear in mind that due to the generation change, physiotherapists, dietists, mental health professionals are regarded differently. Thank you for your contribution. Now, I want to address the audience, on the one hand, the national audience, for you to think about this not being the normal. What is normal is that in the majority of the countries, the collective, the healthcare collective would be close here. So your claims about this specialization in social work and in healthcare social work means speaking of the future for many countries, a future that is now not a reality yet. So I want you to consider that these 3 collectives are part of a single team, and we would have liked to have representatives from other sectors of this team. You all are part of the core of the healthcare system, of primary healthcare. Now, addressing this flexibility, I would like you to speak about how you deal with the management of the claims, the demands that our patients experience. And also, I would like you to speak about the administratives as guiding actors or as active part of the triage of the sorting. So who would like to start speaking? Well, since you all started me, I will begin. I think we are in the middle of a turning point. We have to bet for a different organizational model, another management model. For us, at this point, the most important part is that we are not staff, we are a team. And that works, that we all work together to answer the claims, the needs of our citizens. And every one of us has a very precise work to do, but we are all entangled. When it is a very acute, when we deal with a very acute problem, the administratives have to derive the patient. We have a new competence, a new skill that is being learned by nurses, which is this management role. But also have the non-communicable diseases, such as aging, such as diabetes. And here we need to work in a proactive manner. We don't have to wait for the patient to come. And that means that we have to work at a population level. We have to know about the population that we are assigned to. We have to know about the demographics. As a team, we should have a diagnosis of the territory of the land we are working in. And we should bet for a director, not a coordinator, but a true director and a self-sustained team with a strategic plan that should be approved by the team itself. And this is the objective, this is the target. If we just focus on the leaderboards, of course, we have to give credit to the regional representations of healthcare, so not the national one, but also a regional one. This is something that we really appreciate. For in the end, nothing would work if we didn't have a dedicated budget, and this budget should be increased for 25% is a number that we listen a lot, but we are rather getting a 17 or even an 11% of the whole healthcare budget. So we should work as a team that we are. Nurses are our very appreciated teammates. In a doctor-centered setting, we have to vindicate, we have to claim for a change. Not everything has to go, not everything has to be attended by a doctor, in particular not the bureaucratic part. And nurses and the other actors have to play an active role. I would like to make a point here. You spoke about populational health. I would rather speak about population necessities. So this is the view of how the future should like in healthcare centers. A future where healthcare professionals play an active role, because we are in the end conditioned, bounded by our surroundings. We have Jose Cerezo with us, who has published a policy paper on the management, on population health management, and he is a clear reference, for he provides us with examples of tools that can be applied, that can be used. There is a set of tools that are useful in this context, and it embraces all the non-healthcare related per se issues. And it also makes a point on how skilled you are when addressing this management. So we pass the mic. So we social workers have this holistic view where we try to work with the person globally. From the times of Mary Grace, our founder lady, there was spoken about the case-founded approach, the need to talk to the people, but also the idea that the person should be understood as a whole, that is, addressing the family, the environment, and the personal conditions. So we focus on the individual, fostering their knowledge on their own, and this self-knowledge is also enforced by an educational environment, by a family environment, by a household environment, and there is a series of stress factors that arise from this context. And this continuity that is linked, that is bounded to the social, is managed historically by the nurses. And we play an active role, we social workers, on the adding of the social issues to healthcare. So let's face the example of somebody who has undergone hip replacement, who lives alone, has to go upstairs and has nothing to eat because he lives alone. And he also has to cook for himself. So facing such a setting, we try to build a holistic approach, a comprehensive approach that should be added on to the team's plan, and this vision should be comprehensive. It goes beyond the wheelchair. The wheelchair has to fit in a house. And we also have to bear in mind that there is a material setting that should not be disregarded. Sometimes I like to speak about transdisciplinarity, for we don't have a common language and we don't understand each other. So that time, this common knowledge of the group, of the team, we're also physiotherapists, should be regarded, for example. This common knowledge should be expressed in a common language. We should share a lens, we should share, if you allow me, glasses that would help us see and address these problems correctly. And we should also address reincidences, frequent patients. And sometimes this is but a result of unsolved problems that arise from the social context. Okay, Miguel. Now I will round up by going a bit further. First, by addressing Remedio's claim. We are very engaged with teamwork, and we are aiming for consensus, for a horizontal approach. We'll bear in mind the new work dynamics, but in order for them to be implemented, we have to change many things. And there are two fundamental aspects: the one regulating drugs and the one regulating education. We should find a final solution to elude steps that are redundant. And in order to do that, we should rely on scientific evidence. So all our claims, all our work is headed towards the approval of the Ministry of this work, to this qualitative leap for these politics to be implemented. We should not be experiencing the problem of facing trials for having done things that are not within our reach. But sometimes we're not given the alternative. And I'm speaking about prescriptions. So sometimes we know that we can work very well, both nurses and family doctors. The work is being done, but we need this political and social foundation that should support all this work. From the perspective of all the work that is being done, I like speaking about health diagnosis, something that was developed in the 80s, by which PHC was successful. Is something that has been abandoned progressively. Now, we have to know our community, and we have to know the processes that appear in that community. We cannot have the same populations, this is what I was saying before. For depending on the populations, depending on the samples, we will draw different lines, different strategies. So it is not sufficient to have the income of our neighborhoods. That's not enough. For this is the only variable that we are using to dedicate resources for one center or the other. We have a psychosocial approach, and we are very sorry for the cost cuts in the social dimension. For this has to be implemented via social and community strategies. One of the key competencies is that which addresses the final line of the patient's development. And here we speak of case management. And here we don't only mean that which is purely health, but also the family setting. In the end, we are caretakers, and we know about care, in particular in the Mediterranean area. We know what care is. And we know that the caretakers should be cared of, and that they should be appreciated. Thank you, Esther. I think during this discussion block, we could have a recap on teamwork, on demand management, and those claims that are also part of primary healthcare. So from my side, I cannot but invite you all, our audience, to raise their questions to our panelists. I see a raised hand over there. Hello, I will start by expressing my reflection. I've been here for 7 hours, and I haven't heard the word pediatrics in the whole day. You didn't mention it for a second, and we are also part of the team. There isn't any PHC professional that works in pediatrics in this roundtable. I want to claim that we are also part of this team, and that we face very similar, if not more, problems that you do. And we are left unseen. And I want you, organizers, to take us into account. And I believe we should be in the forefront from the ministry, so that we may gain visibility in other settings. It seems like we pediatric experts don't exist, but we work with 7 million children a year. I'm Guillermo Martin, Vice President of the Pediatrics Association of this country. Thank you. Thank you for that contribution. As a coordinator, I must admit that you are part of the technical committee of the leaderboard, and you are normally also invited to all the sessions that we celebrate. We didn't get into detail with the specializations in this case. However, we accept the comment and the critique. I cannot listen to the question if no microphone is used. So my claim is simply that we are also part of primary healthcare. And this is what I want to convey. The same as we have nurses, social workers, and family doctors. I'm happy about all of them being there. I'm also happy about having heard about the administrative part, because they are also part of our healthcare centers. So I thank your intervention. But if you have any proposal, any claim, I think this is the moment. This is why we are raising these questions, so that every member representative from other collectives may join the discussion. So if you have any comments on the topics that we addressed, you are more than welcome. Hello, I am Paloma. I'm a midwife. It goes a bit in line with the question of my colleague. Why aren't midwives considered as part of primary healthcare? We provide support to the women, which are half of our population. And midwives, as Thomas said, a good friend of mine, is one of the best professionals that we may optimize within public healthcare. We are not doing it. We are field staff. We are not a reference for the women. So going beyond the lack of mentions to the midwives being done along this day, I want to raise a claim on the integration of the midwives in the conception of healthcare. Thank you. Well, Paloma, I am afraid that I have the same message to convey to you as I did for our pediatrics colleague. It is your time to raise your proposals and comments on the topics that we addressed. And I believe that the work of midwives, as you are also part of the technical committee, your voices are heard and your opinions are considered. So we will be happy to hear about your opinions and views. I just wanted to make a comment on the fact that we are calling attention on the existence of midwives, pediatrics experts, dietists, and so on and so forth in the Spanish healthcare system. So we are really celebrating this diversity or this transdisciplinarity, as you were saying. So I don't want you to feel excluded, because this is what we are very proud of. This is what we are celebrating here. Same goes for Tomás as for the rest of WHO units. We are celebrating the Spanish model precisely for this reason. But it is true that we want to give you the space to make your comments, to share your views. Hello, I am Juan Antonio Caballero, responsible for the neighbors' healthcare defense, so not part of the healthcare system. I wanted to convey the main idea that the citizen is sharing, which is of great satisfaction. When we are before our doctors or before our nurses, our problems are gone. And this is what I want to convey here. It is a reality. Now, where is the problem? The problem comes in sitting before the doctor in these 8, 10, 20 days that we have to wait for our doctors to see us, for us to go to the practices. But once we get to the doctor, once we get to the nurses, our problems are over. Now another issue, speaking about the coordination which is needed. It is understood that the one who is coordinating that is the patient. So the patient should be in the middle, and the rest should be customized, should be adapted for the patient, for the user to be attended. And it can be attended from different sectors. It doesn't have to be a doctor, a nurse. It can be whatever you may call it. But the center from which the optimization is driven is the patient. And this is what we have to remember. This is what we have to bear in mind. And now I will raise a final question. What is the role that you would give to a neighbors association, speaking of neighbors, that overlaps with the neighborhood's healthcare center? For sometimes we only have one per neighbor, or two at most. So I would like to know what is the role that we can play. For it can also happen, due to the lack of resources, that we are told to do things that we cannot do or that we should not do. Now in Spain we don't speak, now we have changed the name of neighbors associations. It's a minimum change. So who should begin? Well, we are developing all the strategies for community healthcare in which we are looking for reference within the communities. And neighbor associations are our reference points. These are the ones that will be addressed and asked for us to learn about the neighbors' necessities and needs, for us to outreach these communities. So we want you to tell us how to improve the neighbors' health. So it is first-hand information that will be provided addressing the hot topics of the neighborhood. And this may drive the development of a series of initiatives that will also help us coordinate it with different entities, or raising a call for funding, for resources, for we know that these needs are unmet. So I believe inside of this community strategy, community healthcare strategy, this research management that can be enhanced by you as healthcare assets is a very valuable one. And you can also receive a feedback from us. And we also know that you will provide our patients with a comprehensive advice for the integration of healthcare in the neighborhood. So I think we should have communication and coordination. I must say that I fully agree with you. We are allies in this fight, and this lack of accessibility and this delay is what we have to claim for. And we experience a need for accessibility. I see in your centers there are big delays. Not everyone experiences them, but you are the ones who should raise their claims for that. I am happy that you raised this question. For the philosophy of healthcare goes hand in hand with being very close to the community. We have to consider the resources, the healthcare assets that might be spread, that might be scattered in the community. We, as professionals, should look for the compatibility, and we claim for having enough time to develop this work, this community work, that is also the savior of undesired loneliness, who is also the key actor in the connection of health networks and support networks, and which are the best way to connect. So I consider that you are a vital actor in this process. And you are one of the key healthcare assets. Good afternoon, everyone. I am a healthcare user ever since I was born. I was brought to life by a midwife, and a doctor may close my eyes, but I am also part of the healthcare system. Healthcare belongs to us, and it is us who have to manage and who have to share responsibility for the whole process. For we are lifelong users of healthcare, and since I am part of the ministry, I call for the general law of healthcare, for healthcare councils, for basic needs, healthcare councils at a district level, at a province level, management councils, direction councils. A program contract balance. How do they participate, our citizens? Through you, through the teams. But it is not you who should outreach to us. It is us who should go to you and drive the decisions. Before, you were pointing out at the healthcare centers at the municipal level, where everything is decentralized, where it depends on the available resources, what is done. Where the positions are not consolidated, where we are in need for more public work positions. And I don't tell this to you, but to the administration, to the public administration. It doesn't matter who's in charge, public health has to be defended. I think this is the best occasion. Do you hear me? I think this is the best occasion to move into the third block that goes in line with this direction. And thus, I would like to present Carolina Escobar Madero, Cristina, who's also the president of the Platform of Patients Organizations, member of a number of committees and associations representing the patients at different levels, and has collaborated hand in hand with the ministry. She has suffered illness from a very young age, and she is an expert patient, a concept that I share with her, and she is a reference for many other patients. On the other hand, we may welcome Manuel Martín García, who is also a doctor in SEISO, Pontevedra, and who holds the chair for the presidency in the Federation of Associations for the Defense of Public Health. Welcome. In this block, to frame the topic, we will try to discuss the innovations and improvements in service providing. We will start with this two, but we will also give the floor to other collectives who would have the opportunity to raise their concerns, make their comments on these topics. So my first question is from the user's perspective. What are the challenges? At the beginning, I thought about problems. What are the challenges that we may identify in healthcare? What are the challenges? And then we will speak about the opportunities.
Well, the first challenge, some people already talked about it, is the very severe problem of accessibility that we have right now in primary attention. In primary healthcare reality is what it is, we all know it. Sadly, we have high delays that go over a week of delay. We have professionals that have less professionals that they should. Obviously, the circumstances are not the same in different health centers and different autonomous communities. But the general norm is that health centers are being closed. Maintained attention centers have a lack of professionals. Problems of visibility through technologies, margin all the elderly population, or the population with less training resources. And this is a problem. Another problem that we have is the problem that the system is right now focused on the disease. We have a system on which the promotion, prevention, and rehabilitation, except some exceptions, it is not the general norm. Disease or medicalization makes us have in one part demand on the medical consultory. More than 80% of demand are directed to the family doctor or physician, and this means, apart from the lack of professionals, a massification problem. Consults are massified, there is not much time to attend the patient, and let's not talk about promotion, prevention, or work with the community. Because most of the time, professional is dedicated to the medical system, obviously the needs and the demands of the population are not going to be satisfied. And this also has a bad outcome on the health professionals, because they're going to have problems that should not be their problems, are problems from the midwife, the social worker, or whoever it is, but not the physician. The problem is that this physician is frustrated, saturated, and this explains why there's a lack of professionals in many centers in Spain, because they want to leave, because many professionals, they give up and they say that the situation, they cannot deal with the situation anymore. I think we have a very serious coordination, internal coordination problem inside the primary health care centers and inside the teams that, as we've said here, and I think it's a magnificent thing, right now we're talking not just about the basis equipment, there is a nurse, a physician, or an administrative, but it is to go further away to the demands of the needs that more than 30% of the health problems are related to mental health problems, anxiety, frustration, and so on. We don't have, in many of the health centers, they don't have clinical psychologists or people that have rehabilitation, breast rehabilitation problems, arthrosis problems, arthritis problems, and so on. They mainly don't have resources more than the painkiller or surgery, but we do forget that rehabilitation is the basis to make a person that's been ill become healthy again. This allows me, I'm sorry to interrupt you, we'll have more time then to discuss, but let's share more information. And I would like to hear what Karina has to say. Thank you very much for inviting the patients in this case. And as you ask, the main challenge is that 85% of the population that has some disease, 54, has some chronic pathology. And this increases as we get older. 19% of the child population has some chronic disease. We're in a situation where each time these pathologies and diseases, chronic diseases in our teenagers and childs appear earlier. So it is a chronicity challenge. It's a very important one. And also I want to talk about some data, some numbers, to understand what's happening with the patients, to understand the unsatisfaction that we have after the pandemics that went over all of us, the patients, the professionals. When we're talking about perception of attention, we've talked about many points. It seems that we are not grateful, but the problems have raised. Just 11% of the patients, according to our studies, say they are okay or very well. The majority of our patients, they are in a situation of a health problem, and they are not getting better. There's an important data about diagnosis. Patients last between 2 and 2.5 years to get a diagnosis of this illness and sickness. So when they actually know what was their problem, they have been already waiting for 2 or 2.5 years. And last but not least, just 43% of the patients, they do not understand their doctor at the moment of the diagnosis. This means a lot, right? So the thing is how to accompany the patient better in all their health process. I do have many pathological diseases, and I want to talk about this. Chronicity is very important in primary health care. Not just getting to know the disease, but getting to know the whole pattern of chronicity. Our more affected group is women, 80-year-old women with low economic resources. And lately, I don't know if you've noticed, but they are going alone to the medical practices. So they receive less quality attention. Thank you very much, Karina. Thank you very much, Manuel. I think what you were saying, Karina, about integration and not losing the focus on chronicity in primary healthcare is one of the lines we're working on in the minister, to having the complex chronic patients in the focus on the interventions, and to think what kind of specific interventions for this group we could have. Next question that we would like to make you is, what role can the community attention play in your perspective for this type of patients? What does this give to you? What benefits do you have from this primary attention, community attention? How can the health center act as a catalyst inside these four walls, and what's important from your point of view, from the patient point of view, and the most complex and chronic patients, and the social society? The main problem of the community health is that despite the speciality of family medicine and medicine, the community matter mainly has a little role in the curriculum of training in professionals, of health professionals. So when the professionals do not know the community model, they are focused on the training on the physician and the nurse more than the disease itself. That's why we have high levels on drugs utilization. And this is not because the physician or the doctor, they don't want to do their job right, but because they respond to their training model, as well in the university as well as in the training processes after what they've studied. This means that all this community matter about how can we planify the needs, how can we identify the needs with a health diagnosis if the population does not participate, and they do not participate because we don't have the tools in many of the places. It is true that there are some exceptions, but that they allow participation. Who planifies? Experts that do not have the perception and the need to identify, as my colleague was saying before, that they do not participate. So they are experts with a very good training, but that they not respond to the planification and execution of the resources to the needs of this community. So I think it is key, the community, to identify the problems. It is key, the community is key to value the quality of the attention that it receives, because many times the patient, probably because they don't, the demand was not answered right, the patient usually goes home with a big frustration. So we have to measure the quality. And who can measure the quality? I think all the experts in quality says that the users, the service users, have to be the ones that measure the quality. So it is a basis to include the community to evaluation and evaluation. And it can be very good to the teams because it can correct effects that are probably not identified, because population and professionals are focused on different things, and they can complement themselves, and they can enhance in a very good way the quality of attention. Perfect. We'll keep this idea. I think it's very good about how to complement or redirect these services to the real destinies, the ones that have to receive this. Karina, please. I think the combination of primary healthcare and community is it's a key point, because because doctors do need the community. We all have to work together. It's not just doctors tax and here and community and here. We all have to go together. How we do mature as a society. in knowing our own health, in take care of ourselves. We have to work a lot on co-responsibility. I like more co-responsibility than empowering, because co-responsibility talks about all of us, patient, professional, and everyone. And I think this is a key, especially when we're talking about chronic disease patients. It is important to work all together. I think that the figure of people that with their own experience can give their own opinion, I think they have to be in the community and they have to work within the doctors and the professionals. Here we have the neighbor associations. They travel with us, we can say. And we are right now in the moment that we've gone through a pandemic. We have to get through it. We have a digital barrier. Studies say that people older than 70% have these problems because they cannot communicate with a doctor. So analogical and digital have to work together. The community can help to this goal. And what we do is to go to every council, and we're doing good things in every council, and we need to check this, to see this. We're going to see this in the future, but the present is where we need to work. Thank you very much, Karen. I would like to just add something, some little thing. The problem about how to act, how do the health centers act, the primary health centers act. Well, the most important thing is that the things that determine the health. We are focusing on new teams of radio diagnosis, blood testers that tell you when can you have a disease, but we don't act on the things that determine the diseases. And who's the main element on the system that can work on this? Primary healthcare and public health. But we are not coordinated. The health areas, that is a tool from the society, was saying the obvious need for this coordination between public and health professionals, and act before the problem, not wait for the problem, to prevent from work risks, sedentarism, and so on. And here is health centers who really have to take a part on it. So to open this debate that we've been talking about, I think it's fantastic. Raul, you give me a perfect opportunity to talk about how can we increase the value of primary health care even above the national health care. The question, and right now you do not have to refer to the ministry or the scientific societies. What is the power and what's the role that the citizens can play as voices to increase this value of primary health care? Right now, you see, I'm giving you the turn to talk so that as co-creators of this system, to tell us what's your voice, what's your power. Well, I think we've moved forward a lot in participation. It's not the one that we would like, but I have some data here because it is not clear what we do from a health point of view. We do not substitute anyone, but inside participation, in what we do in patient associations, inside what we do, how we contribute is to enhance the quality of life of patients, co-responsibility, and all the things related to management of the disease. We, patients, want to participate as changing agents in the sector, and we want to work with other professionals, participate on public decisions, and on the research area that is a key for us. We are asking for this high participation in health research and to participate with other associations that can work and be another agent. What we're doing is work for professionals, not for professionals, but with professionals, with decision makers, and so on. We participate in a lot of things, but we didn't study on which we saw the impact that we do, and 60% of our entities had participated in health policies. But when they see the reflex of their participation, is not even the 20% of what we've proposed was actually introduced into the law. So we are inside the primary healthcare in different autonomous community, but we think we can participate more. Different challenges that we have as society and that we can help with, even all the data, European space, and many things that the patients, we are the closer entities to the real experience of the primary healthcare system. I think we have to keep on moving forward because we are already working and developing initiatives in this sense to create allies. We have to have a social collaboration and professional collaboration because we do share the same problems and we do share probably the same solutions, or at least moving forward lines in this case. So the empowerness, also don't like this word. What I like is the social power has to get linked to the professional power to force the administrations, to the people managing the resources, to adapt the decisions that we need. Because we can have the reason, we can have perfect analysis as the ones we did here. But if we don't have a social power that supports this, we're not getting, no matter how good the governments want to do it, we have to make these changes possible, and we need this collaboration between professionals, patients, that we are right now in a very complicated situation. Thank you very much. And now I want to give some space to the zero line, some of the components that we offer them, and that we offer them to talk. Some of you did talk, but we're going to give a second chance to the rest of the people. So for this, we have Mariano Pastor right now with us. Mariano, please. Are you here? Mariano Pastor? No? So I'm going forward to Rosa Gómez Honorato, Platform of Health Centers. Yes, please. Can she have a microphone, please? Thank you. Good afternoon. The Platform of Health Centers that I represent today is composed by workers from all the health categories and not health categories in the health centers in the community of Madrid. This platform believes that it's a time of a paradigm change, stabilizing a primary system for the primary healthcare, on which primary healthcare is the basis for the health actions and guarantees the continuity along the life of the patients, coordinating the relation within the hospitality attention, extra hospitality attention, because PAC right now do not have doctors and they do not cover the whole time of the health centers, coordinating as well the mental health, social health, public health, and correlations with citizens. With this, we will get the goals of decreasing the hospitalizations and heterogeneity, avoid problems, enhance the use of resources, and to reduce the costs, the material and the non-material ones, about the life quality. Obviously, we don't need for this an information system informatic system shared and understood, complemented with an university training with a specific department of primary healthcare. It will have research capacity and, of course, an adequate financing. This change on the value on the primary healthcare will give us some attractive and will help us to maintain the talent that we have now. We need to have the teams integrated apart from family physicians, nurses, pediatrists, all the disciplines needed to reassure the quality of the attention. As midwives, physio, psychologists, social workers, and even pathologists. Considering all of these professionals, main parts and not just support members. We want to enhance the importance of administratives with a important role right now in health that is a key for the patient and for the organization of the work of the teams. We want also the ministry to keep on going forward with their strategy and to get special nurses in community and familiar. We will need the revision of the services, including new prestations, mainly about mental health. We do not forget the community perspective and participated on the management with periodic audits shared with the citizens. For all this, we do need the implication of workers, citizens, and political will. Thank you very much. Thank you very much, Rosa. And now, Juan Antonio Caballero from the Estatal Confederation of Neighbor Societies. As I talked before, I'm not going to talk much. First, to declare that our confederation and the autonomic confederations are will to collaborate at the maximum level that we can within the administration, in this case the ministry, and the autonomous community and communities, and of course the organizations. I don't know if to call them health organizations and social organizations. This is a principal declaration. And our only condition is to just follow the path that we've talked about here today. Also to talk about the importance of networks and the public media. When I was little, I saw in the TV a man that said he was a doctor, but he wasn't. And he said what you had and do not have to do. And I think inside the community attention, I think these two things, nets, internet, and social media, have to be committed in this field. Thank you very much. And now Maria Carmenes, the General Coordinator. Thank you very much. I am Carmen, and I also represent TAC, from which I'm a representative of health. It is true that it was very interesting, this institutional act, in which I saw the citizens were not represented. In this title role that some people said, that is the one that really is being the one responsible of all services. I think that Spanish public health and primary health care in Spain, its prestige is wonderful, and because of what I know and what I've seen, it's not comparable with the other European models. But I do think it should be should go to other models as a model to follow. But a model that right now it is falling down, and it is not about society changing, it is about the system. The diagnosis is very clear. The diagnosis is that we have a model named neoliberal model that puts the market above the health, and we cannot admit. We've talked a lot about money. Yes, there are people that do have money, but they don't have professionals. There are people with money and no professionals, but there are some policies that are really evil, so that health is on the focus of every politics, and it's something that we've been asking for so many years. Year 2019, we made a special act in the Deputy Congress that was called Primary Attention, Primary Model, the one defended by the healthcare system. And this model is the basis and distribution of what means health for the whole society. I don't want to say this in a rude way, but yes, in a clear way, and I think we have to recover the language. We didn't like the transforming word, because we think that for our model, we don't have to transform, but to rescue. We didn't like to say that we are users. We are, but mainly we are the main characters. Some of them, we are patients, but all of us, we are main characters. And as that, we have not been consulted. We have not been attended. We've asked for a meeting since 3 months ago, and we're still waiting for an answer for this meeting, because we have many things to say. We are the basis of society. We are not health professionals. I am not as well. But in the white waves, there are many professionals, and we all think the same. We defend the national health as a tool that can keep our society safe and that can control with primary attention, that has to have a right financing, good professionals, and enough professionals. I said a good financing because they give money, but they do not control the money. I say this because in this model of autonomous community, many money has been distributed but not controlled. And I ask for the money to be controlled, because this money is being used for other things, and we, the citizens, do not have support for attention. And I don't want to go forward what I'm saying, because I think many things have been already said, but I think it's basis and key that to clear everything up, we have to go back to the health law. It is a good law, but we have to clean it up. So please, do not keep on going with what we are doing now. We have to clean it. And the health law got dirty with the privatization law. So we have to clean it up. Really, all this made us look for a change of name of the citizens, so we are not longer patients but consumers. And this is where the white wave started. I think it's well that the ministry works within other ministers and have the health as a priority in every politics. And we also say that we do not agree with the public-private or private. The mixture, it's dangerous. And here in Spain, we've seen this. So obviously, we do want control and order. We want inspection in every level, in the communities, and also at health ministry level, a high leadership in the health ministry, on which we will participate and support to forbidden these lobbies' interests, to attend these citizens that we do want to collaborate with the institutions without asking for anything. We do not get money, we do not want money, we work for the human right for health. And we want also that primary health care, this that you say you want to transform and we want to restore or rescue better, it has to be personal. It has to have a prevention and promotion activity. And attention is is in the second line. Health centers are rare. Yeah, I'm finishing. I think we have to enhance more health centers. Attention and this digital gap. This is something we need to help with. But the citizens, the patients, and all the citizens, we do not want to see our doctors, our physicians through a computer. We do not want to take care of ourselves through a screen. We want to do it in person. And I have to say, health is an investment, not a cost, and health is before the market. And this is what we're saying 7 April in all the European network, defending what I'm talking about. And I sum it up because we've been here the whole day, but we just had 3 minutes to talk, and I hope we will have more time to talk in the future. And also we have to stop privatizing, separate the public and the private, and control the money and the citizens present in all the levels, as my colleague in front of me said, that she talked about this before. Thank you very much, but I think it is super important to take all these things into account, because we have to go through to the village Europe and not the market Europe. That's the one that the European Commission is using. Thank you.
Muchas gracias, María Carmen.
Thank you, Maria Carmen. Juan Antonio, please. Rosa, all your interventions were delightful. Well, I believe that we have heard the voices of the people, of the civil society. We are aware of not being able to listen to everybody's voice, but this conversation continues. And we want this conversation to continue. We want to make it possible. If you allow me, I will make a last question addressing the international representatives. So if somebody wants to share a short reflection.
And to give some reflections about this session today. So what you've seen about the Spanish model, very briefly, and if not, we'll go to the next step. Y si no, seguiremos con la.
If it is not the case, we will follow with the closing of today's event by the General Director and my colleague, Tomás Zapata. Paloma, you have the word. Thank you. Well, then we will close this roundtable where we listen to very diverse voices. Some of them participated in an open forum for the first time, some others not. Some voices may have left unheard, but I want to insist on Tommy's idea that our vision, at least from the point of view of these co-joint strategies with all organisms, with all societies that want to collaborate, is to keep on working on the development of forests like this that will help us foster a transformation or a redefinition of primary healthcare, which is today's topic. And before I close the act, I want a big applause for all panelists and a little excuse for the colleague from Castilla-La Mancha, had to take a flight and she needed to leave before. So a big applause for everyone.
Bueno, pues continuamos.
So we follow up, heading to the end. We're all a bit tired. And I would like to start thanking all the participants, all the panelists from this roundtable. I really like Tony Deo's closing, for this is the beginning. It's but a reflection. It does not end up here. We will have more open spaces for reflection. We will have more meetings. We are heading to the end of today's event, and I want to thank all the attendees, both in person as via streaming, as well as everyone who made this event possible. First, the whole team from the regional office of the WHO, the Ministry of Health, starting by the PHC team, the Secretariat. Thanks to the interpreters and the colleagues from the Ministry who helped us making this event possible. They helped us with the logistics, with the press, with the video conference support. So now I am honored to present the closing that will be held by Pedro Guñón and Tomás Zapata. Now it is your turn. You may begin. There we go. You will allow me, now that I have the mic, to stand in the middle. Nuria did something perfectly, which is not leaving anyone behind. So I just want to say, follow Nuria's advice, for she did everything correct. So thanks everyone. It was a beautiful act for me, and a beautiful beginning of a series of dialogues. I will also claim for the concept of transformation. We may call it otherwise, as a situation of the challenges of all the values that we have been speaking about in today's setting. Communitary setting, trans and multidisciplinarity, the longitudinality as a rear axle for primary healthcare. And we have spoken about Spain and why Spain may be a philosophical reference as a starting point and as a place to come back in matters of public health and primary health care. Now I want you to read the reports we have been discussing today, for they are accessible both for healthcare professionals and for laymen who are interested in the topic. We have also spoken about the primary healthcare transformations in Spain. This first report is interesting, for it provides us with a very interesting approach. In here you will find a good deal of trivia to learn about how our system works internally. It is also very useful for us from the ministry. And we have to be critical, we have to vindicate our values, but we also have to be critical about the Spanish situation of public health care and primary health care. But also the primary health care approach and its implementation that was presented today is an important and interesting read. That was the first roundtable that we had in the morning, the one I participated in, where we discussed the different models that we have before us and how we can combine them. In the afternoon, we landed in Spain with this interdisciplinary, interregional roundtable where we discussed the particular issues of the country. And I really like this final part, for there was external participation. We could hear other voices, and I think this might be the beginning of a very valuable follow-up. I just want to say that starting from this value and looking towards the future, we have to work for an improvement of primary healthcare. They are all things that should be implemented in the future. Coordination work, universities, participation. We will speak about primary healthcare. We'll speak about the population's health and how it can be integrated through community healthcare. Thank you. So I want to thank everyone, also you. I didn't thank you before, so I thank you now. So I want to thank the whole ministry. It has been a pleasure to be here, to work together, this program, and everyone that will follow. Last week we were in Copenhagen, which gave us the opportunity to explore different areas for potential collaboration. I think we have observed that our model performs very well when compared to other countries in Europe. But we find ourselves in a crossroad where we face a series of challenges, societal changes that call for a model transformation. I also go for the term transformation. That is also a word that implies progress. So moving forward, adapting and progressing. This is how I understand the word transformation. And I think the minister, said it very well. So we have to prioritize primary healthcare for this transformation to take us to a better future. In this last roundtable, it was fantastic, for it gave us the opportunity to listen to very different perspectives coming from different regions. It also provided us with examples of good practices when it comes to retaining talent, improving work conditions of our healthcare workforce. And sometimes we don't have to build something from scratch, but just learn from what is being done in other sectors and in other places. We have also listened to the perspectives of other kinds of professionals. We have spoken of interdisciplinarity. But I think all kinds of professionals have to define together the future that we want, and also have to define the roadmap to make it possible. Also, we have to take into account the neighbors' associations. And I think you're correct when you say that everything has to be patient-focused, citizen-focused. And I think this was a very valuable contribution. And last but not least, we are facing a window of opportunity to recover the momentum, to recover I cannot listen, I'm sorry. I believe we have a shared responsibility and we can all contribute, everyone from our sectors, towards a real transformation of PHC. And as they say in Mozambique, estamos juntos, we are together. We have a common objective, and we are moving forward hand in hand together. So I want to thank everyone for this opportunity. Thank you.